All right, I will get started. Okay. Well, really excited to have you all here today. I'm Dawn Ellison. I'm in the core group of Healthcare Reinvention Collaborative, along with Denise Williams and Jennifer Beach
Denise
and Paul
Wiseman.
Burens. I'm sorry.
You
What did
called
I
me
say?
Denise
Williams.
Williams.
Oh, that's great. Denise Wiseman. Wow, that's different. And Wael Sasu, I don't know if Wael is on today yet. Sometimes he can make it at this time, sometimes not. And Keely Gales. So, as most of you know, our mission with HRC is to identify, connect, support, and illuminate the ruckus makers working to improve how we care for health. Last month, we helped Emily Peters and Matthew Holt explore material for Emily's book, Money Remaking Medicine. Today, we have three guests with intersecting passions that, after being introduced at an initial planning meeting for this event on July 22nd, are starting to make a ruckus together. And I expect they will share that with you. So, Denise is going to spotlight them and I will introduce them to you in a moment here. All right.
Give me just a moment while I find all three.
Okay, well, I can start with Kathleen if she's up.
She's up, yes.
Kathleen is a nurse and public speaker who has spent 25 years addressing cultural issues in healthcare. During the pandemic, she and three other nurses founded Nurses Transforming Healthcare after realizing that poor health outcomes stem from the structural problems rather than processes or people. She's currently developing a white paper and a playbook for flipping zip codes from sick to well and transforming healthcare from a business model to a service model. Welcome, Kathleen.
Thank you.
Sara Pastoor is a family physician and the first physician hired by Ellison Health, a primary care focused EHR company, where she advocates for high quality, independent primary care. She practices in both a direct primary care clinic and volunteers at a free clinic for indigent populations, teaching pre-med students the art of medicine and humanity. Her mission is ensuring every American has a primary care provider they know and trust, free from the conflicting revenue agendas of hospital systems and insurance company. Welcome, Sara.
Thank you. Hi, everyone.
And Victor Guajardo is a medical consultant who builds innovative healthcare plans for large employers using cash-based payment models that eliminate traditional insurance middlemen. He specializes in direct agreements between employers and healthcare providers, achieving 30% cost reductions while focusing on clinical outcomes and member satisfaction. His work involves complex underwriting and forecasting, with a particular focus on helping school districts implement transparent, cost-effective healthcare solution. Welcome, Victor. So the format for today's event is that you're going to hear from the guests about their approach, what their particular passion is about. And then we'll step into benefits of integrating these approaches. And then we're going to ask you, the participants, to participate and ask you who is all in, who really wants to step forward and make this kind of thing happen. So I'll start with round one, approach of our guests. So in our first round, each of our guests will describe their approach in about 2 to 3 minutes. And Sara is going to go first. Sara?
Yeah, thank you. Thank you for having me and welcome, everyone. I guess if I have to describe my approach, I would start by saying that I am very passionate about primary care as an important lever to help fix our broken healthcare system. Um, and the more we empower primary care, the more leverage primary care will have to make that impact. But we see that, primary care in our traditional healthcare system has been pretty debilitated, and robbed of the autonomy to do what's in the best interest of patients and to do what primary care does best, which is promoting better health and wellness and preventing sick care downstream. And so Elation believes, and I believe, that primary care belongs independent. And by independent, I mean separated or divorced from hospitals, health systems, and other entities that have a secondary revenue agenda that is in direct conflict to what primary care does best. And so there are various models of that primary care independence, but we do know that insurance plays a big role in introducing toxicity and taking that autonomy and independence away from primary care. And so to me, the best version is direct primary care. That's how I practice. And that is where the both the clinical and the financial relationship are one-on-one between me and my patient. And that is where I am the freest, really, to partner with my patient to decide how, when, where, what care is going to be delivered. And, we can do this omni-channel. I can meet my patients in a Walmart parking lot if I need to. I mean, we are reinventing the rules here. But, not everyone can do that. The beauty of direct primary care is that we see you whether you have insurance or not. We just don't bill your insurance. But employers can pay that fee. And there are also, organizations that are direct to employer. There are other primary care models that are, separated from these other influences. But what we're trying to get at here, I think we all know, is that sacred relationship between a primary care physician and their patients. And when I can leverage my clinical expertise and channel it through that relationship, that's where we really start to make an impact on health, where patients know how to self-manage and where we can really start to improve population.
Thank you, Sarah. All right, Victor, let's hear about your work. See if you can explain it to everybody.
Sure. So Victor Guajardo, I'm a patient advocate, risk manager, medical consultant. So my work is largely working with employer groups to design health plans that benefit their members. I hate insurance and insurance middlemen. My ultimate goal is to actually get rid of all the middlemen as much as possible, right? I think that the true insurance and care should be between an individual and the physicians who care for them. So I do work to implement plans that function the same way, which is largely cash-based oriented systems or direct agreements with physicians, hospitals, and then, of course, taking a very detailed look at PBM contracts or cutting out the PBM altogether and figuring out other ways to acquire pharmacy drugs, whether it's through mail order or importation or any other way to achieve that. So the ultimate goal is really to look at the data that a group presents with, that the individuals present with, and design ways for them to connect with their primary care doctors, with their specialists, that does not cause the plan to become insolvent, and also gets the physicians and everybody involved paid as soon as possible. So really just cutting out every way that keeps money away from the people who provide the service and the people who use the insurance for their health. So that's pretty much who I am and what I do.
Great. Thank you, Victor. And just for those who might not know, the PBM means?
Pharmacy benefit manager. Sorry about that.
That's all right. Thank you. All right. Thanks, Victor. And Kathleen, let's hear
Hello,
about your work.
Yes, I'm so excited for this opportunity. Thank you. So I'm with Nurses Transforming Healthcare, and for the last 4 years, we've been studying how would you improve the health of all Americans. And one of my favorite quotes is by Dave Chase, who says, "We didn't get here by rearranging telephone lines." And the biggest thing we run up to is people not being able to envision, what would replace the current system. And so we looked at the research, and everything we do is based on Dunabedian that said structure dictates process, which dictates outcomes. And what we see is people trying to improve outcomes by looking at the processes. But really what's responsible for the outcomes is the structure. So what if you have a structure, like Sarah said, that where you are free, where you're free to do the right thing, and like Victor said, where there's no middleman, where the community actually owns the healthcare. And so we're really excited about our Flip Your Zip project, which is, if you look at complex adaptability theory, how do you change a system that's so complex as healthcare? Like, where do you even start? And the answer is you create a holon, HOLON, something whole and complete, a brand new system somewhere in the system. And you make that sustainable and replicable. So we'd like to flip one zip code in America in 2 ways, from sick to well, and from a business to a service. We did a pilot project a couple years ago and realized that if you're going to do that, you need a new set of metrics. What are you going to measure besides the basic outcomes? You're going to measure community and caring. So this community ownership really fosters responsibility. And as the community gets healthier and you address the social determinants of health, which more than half of the people seeing primary care physicians have at least one of these complexities, then the community gets healthier and you take the money and you can pour it back into the community. And that's really exciting because what we've seen is that it's freeing to do the right thing. I mean, if you just said to a community, to everybody, you're free to do the right thing and this community will support you, people know what to do. I mean, I think that healthcare can be as easy as a public utility and as accessible as a public utility.
Great. Thank you, Kathleen. All right. So I want to put up a poll now. Denise is going to put that up for us to find out what is the biggest problem that you see with primary care right now. So what's your biggest frustration with current primary care access? And go ahead and respond to that poll. And we'll see what people come up with. How many? We've got 9 of 24 responses. Let's see if we can get higher than that. We've got several of us that maybe won't respond, but okay.
I can't see the last one on my
7%.
screen.
It says other. Is that what you're looking at?
I don't see that.
It does scroll up and down.
Okay.
Kathleen. Yeah. There's a bar on the right-hand side. Does that work?
Yeah, there was no bar, but I got it.
Okay, super, super. All right, 19 of 24. I bet that's what we're going to get. So fairly evenly divided. There's a little bit more that talk about rushed visits and, of course, navigating insurance. Had there been an option to express frustration with all of this, that might have been the most popular response, right? If it was all of the above. So what we'd like to do is address some of these issues by talking about how combining these approaches might solve them, these approaches that you've just heard about. So let's start with Sara. Sara, how does your relationship-based model combined with Victor's payment innovation and Kathleen's community approach transform accessibility and patient experience? How might that work?
Well, I completely agree with Victor that third-party for-profit middlemen are in the way. It's creating a lot of bureaucracy and rules that are restricting the ability for patients to get the care that they need and for physicians to provide that care. In San Antonio, Victor and I have started working on a project together that we're really excited about that I think is not the first of its kind, but is exemplary of what we're talking about today, the three of us, where we are planning to build basically a collaborative consortium of all the direct primary care physicians in my town, in our town, and then through that group identify sort of the best in breed subspecialists and ancillary services that we can identify who will offer us a cash price for services at a discount that very often will cost patients less out of pocket than if they use their insurance with their deductibles. And then we can, begin to build programmatically a plan that we can offer to employers or offer to individuals that gives them complete price transparency, that gives them a relationship with a PCP who knows them, knows their history, spends time with them, advocates for them in the healthcare system, can help navigate their care through, across the healthcare spectrum with a carefully curated network of secondary care providers and tertiary care providers who will work collaboratively with me, the PCP, and other PCPs. Of course, you have to prepare for catastrophic events, and we don't want anyone to go into debt because of that. And Victor can talk about ways that we can build that cushion into those plans as well. But I'm really excited about how this is us as a community coming together to build an alternative that is completely outside that traditional health insurance industrial complex and abandons all of those rules, abandons all of that bureaucracy, no prior authorization. And we are putting the power back in the hands of physicians and their patients. So super excited about that project.
Awesome. And I just want to remind people that these three folks just met July 22nd in preparation for this event, and already this is happening, so that is so exciting. Victor, how do direct payment models supported by community investment and relationship-based care improve the healthcare workforce situation and reduce costs?
So by immediately giving payment to the physicians and those who provide the care, you're getting rid of any issues they have, right? They don't need to hire that crazy back office, or maybe they need less for the back office who takes in payment. You are immediately giving them what's owed to them, right? So that is the part that I'm extremely focused on is, hey, I don't want to keep throwing out revenue cycle management, but that is essentially what doctors and hospitals use, to track payments down and get money in their pocket. And I want to get rid of that, so that way they can continue to provide care, and they don't have to worry about these kinds of things of the shenanigans, right? That insurance flow, if you will. So that's kind of where I see myself in that immediate payment in all of this and how it improves it. It lets the docs do their job, and gets everything else out of the way.
Excellent. That sounds like a plan. Kathleen, how does community ownership enhanced by direct payment and strong provider relationships create sustainable health transformation?
Most importantly, I think it shifts the focus from external interventions to responsibility and ownership. When you own something, you take care of it, your house, your car, you have some say in it. And it does this in many ways. It increases participation and engagement. For example, we noticed that people were more likely to go to health screenings or to join wellness programs or to work in our community gardens. It increases a sense of responsibility. People are more likely to invest their time, their resources, and their expertise. An example from our Spicewood clinic is we sent a woman who was taking illegal drugs for the pain in her neck. We sent her to a neurochiropractor for one visit, and the neurochiropractor donated the next 9 visits because her injury was so severe. And she was seeking medication to help herself with her pain. And, the whole community heard about that. I mean, people were helping each other. And if you could think of it as a network, there were threads that were being drawn, and those threads tighten the community. The Surgeon General's report on loneliness said that only 16% of people feel connected to their communities. New research supports again and again that this connection to the community is vital to our health. Another reason is culturally appropriate care. You can address the unique needs of the populations and ensure interventions that are relevant and meaningful. An example of that would be the Community Health by Alaska, Nuka Health. Another reason is it empowers decision making when you have a voice. I don't think that healthcare was ever designed to be a top-down driven initiative. Look at the success we've had with the war on drugs, the DEI. Look at all of these initiatives and mandates that come from the top down instead of people interacting. We're not built like that. We're not built like that to community healthcare is a community concern. And then, of course, the last one, which I already mentioned, was the social cohesion and trust. I was sitting at a bar, actually, talking about the Spicewood Project while in Texas, and the man next to me said, "Did you say that, there's somebody who needs baby food? I'd give money for that. I just don't like giving money when I don't know where it's going." And that's what we found when we posted on Facebook that there were no fans, and we had a dozen people coming to the food bank who had not a fan or an air conditioner in 108 degrees. A community member said, "I'll meet you in an hour at Lowe's," and bought 10 fans. So this networking, it's a fabric that catches the entire community and touches everyone. And that's why I think it's so important.
Thanks, Kathleen. We're running a little ahead of time, so I want to give the 3 guests time to interact with each other. What is exciting to you about this? Whoever would like to speak up first can speak up. Do I have to pick on somebody? Victor?
No, I think what's exciting for me is so I look at healthcare from multiple angles. One is our entire society falls apart without healthcare and access to care. I also see it as a national security issue, right? If you don't have a healthy population, that's not very good for the outcome of your society as a whole. We all depend on each other. Me more so than anybody else. Like I need doctors like Dr. Pastoor. I need nurses like Kathleen, right? Like we need people who are actually in the healthcare system who want to do something different, who understand that the current system is working. And so thank you to any physicians, nurses, or people involved in healthcare for being on here and trying to create the solution, that fabric that we were speaking about. Because without access to care, right, we need a way to pay for it. Cool. That's kind of where someone like me comes in to design it so that way we can get this paid for. But then we need everybody else who actually does the work. So I'm grateful to be a part of it, and to have so many physicians and people involved in healthcare open to making a change, open to different payment models, and things like that.
Yeah, I think I love what you're saying, Victor, about how this is high stakes. And I don't know a single physician who thinks that the current system we have is working. And so what's exciting to me is that we have options. We just need to get the word out. There is a path. The problem is already solved. We just need to get more people on that alternative path. There's so much innovation potential there. There's so much opportunity to reimagine what we have been taught to believe. I recently attended the Direct Primary Care Summit put on by the AA, the American Academy of Family Physicians. And, these are mostly physicians who have abandoned the traditional system and are now working in direct care. And plus, a lot of people who have heard about it and are interested and are coming to learn from those who are already blazing that trail. And the vibe at that conference is incredible. We haven't been taught to believe that primary care can feel like that, or that healthcare can feel like that. It is joyous. It is optimistic. It feels like finally we can practice in a way that is aligned with our professional values. That feels amazing when you can do that. And when you have felt so oppressed and so powerless for so long, beaten down by a system that really is not built for people, it's built for profit. It feels so good to have an alternative, an escape route where you can be liberated to do what's in best interest of your patients. And I tell you, we need to get the word out to patients. They've been taught to believe that primary care is of no value, that we're just pill and referral mills, that it's just a gatekeeper to, get you to where the real care is going to happen. And that's not where you're going to get well, right? So the patients that do make their way into direct care experience something that they never imagined care could feel like, and they cherish it, and they will not go back to the traditional system. And no one is coming to save us. There's not a government office. There's not a politician. There's not a policymaker. No one is coming to save us. We have to do it. And we have the ability. We already have the template. We already have the roadmap. And we just need to get more people on board.
That reminds me of Jerry Garcia's comment. Somebody has to do something. And unfortunately, that somebody is us. And so I just want to echo what you said about the freedom and the amount of energy that's unleashed. I couldn't get the nurses to charge for their hours. I mean, they were like, but I just want to do this because it was the right thing. But having that freedom is fantastic. And we're going to have to address the shortage of primary care physicians. I mean, it's 82,500 this year. And so with that, we have to build more comprehensive and cooperative models with physicians and nurse practitioners working together to meet the needs. And I can't tell you how important that relationship is. I got a phone call from my community health clinic saying, we just want to let you know that you're going to have a different provider this year. And I said, don't bother calling because you call every year and tell me that. I never expect it's going to be the same one. I don't have a relationship. And when I don't have a relationship, I don't want to share. So what we need is a relationship-based system. The entire system is relationship-based, not just our interactions, the whole system, because that is what is important.
Mark asked in the chat, what about the role of captain of the ship by the PC clinician?
Yeah, I, of course, as a family physician myself, have been taught to be the orchestra conductor, the quarterback. We have many allegories for this. But I also see myself in the role of being, sort of the blocker and tackler, because there's so much harm that can come to patients in the healthcare system. And I'm constantly jumping in front of my patients and protecting them from other people downstream who want to order a bunch of interventional tests that aren't necessary, or, that they wind up bouncing from specialist to specialist to specialist. The patients often are self-referring without really knowing what they're doing, and what harm that can expose them to. It can be difficult to help them unlearn those bad habits that were developed out of necessity because they didn't have anyone protecting them. They didn't have anyone advocating for them. They didn't have anyone guiding them because primary care has been so debilitated, or they couldn't get into primary care at all. So once you have that partner in your health, that changes everything. Now I can start herding the cats and dogs, and I can start putting those fragmented, siloed pieces of our healthcare system into a cohesive plan and translating that to my patient into a plan that they understand and can execute.
You were asking about what's exciting. I mean, what's exciting is just imagining primary care, this relationship-based care, plus this direct payer model, plus the community's needs answered, imagining that in one town, in one zip code, in one system. What would you have? That's a totally different model. And it starts by us imagining what that would be like. Imagining you had the freedom in one geographic area, only 10 to 20% of the needs of people coming to see a nurse or doctor are for medical. It's estimated that 70 to 80% are the social determinants of health. So why are we can't even focus just on the medical, because it doesn't matter if I'm doing everything right for my patient, but they're drinking lead water and they don't have a job and they can't come to their appointment because they don't have transportation, et cetera. As indicated by a story of a gentleman who came to the food bank wheezing terribly with his 32 pages of discharge instructions. He was discharged from the hospital 3 weeks earlier. But in this 32 pages, I found his 2 prescriptions for an albuterol inhaler and prednisone taper. And when I asked why they were there, he said he didn't have the $10 in gas to get to the pharmacy. So this integrated approach of everyone working together and is what's going to work.
So I was describing this to someone sharing what was coming up with this event recently, and they said, is this going to work in a poor community? Just thoughts about that.
Those are, those are probably the best communities for primary care.
I agree.
From what I've seen, just rural areas, especially, and not that rural areas are poor, right? But there's just different access, but poor communities, rural areas. And in fact, I mean, there are some carriers that experiment with something like that. But to your point, you have people who are chronically ill and don't even know it. Boom, you're giving them primary care to start working on those the chronic illness. You also have people who've never been to the doctor. They're maybe 18, 19 years old, and that's their first interaction. And maybe at that point you could get them on a path to keeping them healthy, right? Easier said than done. We were all young once. And then you just have ordinary people who have to drive an hour to a hospital, or maybe they have a closer hospital to them, but maybe that hospital is very predatory. I mean, I've experienced that with some of my clients in Virginia and North Carolina. So it is, I would say, by having that primary care physician there, you're giving them quicker access, cheaper access, right, and more holistic access, and you're keeping everything kind of contained for them, right? We all know that the primary care can handle 80% of everybody's health issues, notwithstanding gunshot wounds and things like that. So I would say yes, like the opportunity for primary care for poor communities is immense. But you also have the other social factors into that weigh into it, right? Like it's kind of like taking a super awesome good teacher and putting them in a school where you've got to get people to actually care about certain things. And so it's very similar. And so you have to play with those types of outcomes.
So I want to bring our participants into the conversation. Anybody who has a question for our guests, what are you hearing that resonates with you? Where do you see promise for approaches like these? What else needs to be considered? We'll drop those questions into the chat. Raise your hand and we'll bring you into the conversation, or put your response into the chat, either way. We'd love to hear from you at this point. Hank, I see your hand is up.
Hey team, great presentation, and I love the commitment, and that's really what it takes from a culture change standpoint, is really invested emotionally people. And from an administrator standpoint, I think the challenge that I'm looking at as I take a long-term view is we don't have near the providers that are necessary to deliver the amount of care that exists. So this is almost a problem that's unfixable. In addition, our government payers, whether you're talking Medicare or Medicaid, or frequent flyer users, they're trying to figure out how do we unwind all the costs associated with this. So I don't see the dollars being available to meet the need that exists, and I don't see the people being available to meet the needs that exist. I know I'm gonna have CEOs out there in the parking lots knife fighting for staff already as it is. So my question is, I see this big ugly machine of AI coming that's going to replace, where we're going, and I think how healthcare is being delivered. So at what point does this become a problem that is through that innovation, like you said, with our cell phones? There's something new out there that doesn't need primary care management. Instead, it's going to be some other digital solution that's more affordable and will meet the needs that exist from a staffing standpoint.
Please, can I take
Sarah, please. Yes, Sarah. I was going to call on
Chomping
you
at the
if you
bit.
didn't. Go ahead.
No, great question, Jake. And there's a few things in there that I want to address. The first thing is the shortage. Particularly, there's a crisis in primary care that is worsening over time. And what I can tell you is that the way is not what we've been doing, for sure. That's what's contributing to the crisis. That's what created it in the first place. And we have primary care physicians who are retiring early, who are 5 years out of residency, completely crispy fried, and just leaving medicine entirely and choosing another career path, who have moved into administrative roles, who are just working in urgent care or in emergency rooms instead of in, true primary care roles because they are miserable in, the authentic primary care role because we've made it so miserable in the traditional system. There are so many subspecialists who we would not need if we had a strong foundation of primary care because we would have a healthier population. These are physicians who, I'm just going to say it, we could potentially retrain into primary care roles. We have lots of options on the table. We can think outside the box. I will tell you that direct primary care has salvaged so many primary care careers. I mean, even folks, I know a gentleman who in his 60s had been working in the insurance-based system for years and his whole career, and was just he didn't feel like ready to stop practicing medicine, but he was just so burned out by the system and he just didn't have anything else left to give. And then he heard about direct primary care and he decided to take that leap. And he opened his own direct primary care practice. And 10 years later, he's still practicing and he's happy and he loves it. Like, we can salvage primary care by doing this differently. It's going to be messy and we're going to have some hard choices to make along the way, but we do have options. And the way that we are not going to do it is by continuing the current path that we've been doing. The second thing I want to say about that is that we live in the wealthiest nation in the world. The money is there. We're just not choosing to spend it on the right things. And, we could change how we're spending money, invest more money in primary care. If we invested in a direct primary care provider for every American, we would at least take $1 trillion off of our total national healthcare expenditures, probably more than that. I think it was 2024, we spent $4.8 trillion total. Imagine if we took $1 trillion of those dollars and reinvested them into the healthcare system, into social infrastructure. And then finally, addressing AI. So I do work for a tech company and we are very AI forward. And there are some who believe that AI is going to replace doctors. I'm not one of those people. I don't think, to me, the magic, the power in primary care is in that relationship. And AI can't do that. AI can make me a better clinician. We already know that AI is better at clinical decision making than humans are. But if AI can make me a more excellent clinician, and then I can channel that clinical excellence through my relationship with my patient who trusts me to be on their side and to do what's in their best interest, that's where we really start to change health, because health doesn't happen in a 15-minute exam room encounter. Health happens when patients know what to do when they go home out into their lives and have to make daily decisions about what they're going to do, how they're going to live their lives, and how they're going to self-manage. And so when they're on board with the treatment plan that we've developed together and they are participating and engaged in their own healthcare, that's when we really start impacting health, along with correcting, the social determinants that are impacting health that's even greater than medical care. So I think there's great power in AI, and I think AI is going to take a lot of work out of the work that physicians are doing and free up a lot of cognitive and time resources for physicians to be more present with patients, to be more impactful with patients. But I don't think AI is going to replace that human experience. I think it's just going to multiply, like be a force multiplier for primary care and for physicians in general. What are your thoughts on that, Jake?
Yeah, I think the problem is going to run into if it's all about the relationship and we can get the answer from a black box, then I don't need $500,000 primary care providers on my staff. I can, replace them with patient navigators at a fraction of the cost, which will immensely lower my, volume out there. So if the answers are existing and we agree on that, I think that model of what that relationship looks like or who that has that explainability talent. I think that there's going to be something new out there that we don't necessarily need. And again, it's going to boil down to just the cost. We don't need providers to do care that some new role, I don't see being RNs either, some new role, some patient navigator that does manage those relationships, that does have more connection in the community, that can go out to the spaces. Otherwise, Amazon's going to come in and replace all of us with a device.
Yeah, I'm guessing there's a both and in there. And there will be replacement of some jobs. There will be jobs that shift, new jobs that evolve. But at the heart of medicine is that relationship, and I think that's the most powerful piece. Maybe there will be parts of this that can be delegated to AI, especially agentic AI, and I'm excited about that. But nothing's going to replace that human connection, not to me. Anyway.
Absolutely. I think it's the relationship itself that is healing, and we will know when AI is successful. We will know that AI has been successful and we have implemented it successfully when nurses and physicians, when it gives both of us more time with our patients.
Lynn, I see your hand up, and thanks for posting her. Denise, go ahead, Lynn.
Well, thank you so much. I'm really happy to be here and listen to this great conversation. I thank you, Kathleen. We've had conversations in the past. I'm very well aware of your model and how wonderful it is. Just to bring you up to speed a little bit, the nurse practitioner role really focuses on health promotion and disease prevention. And it wasn't until COVID that nurses finally kind of rose up to the top of, what we can do for healthcare. And a lot of our nurse practitioner colleagues are disenfranchised with the current corporatization of medicine, that every 15-minute visit. Our brains are not hardwired to deal with that. We're hardwired to do whole person care. And you can't do that in 15 minutes. So a lot of the NPs are breaking away. Part of the frustration is they don't have business education, nor do physicians or PAs for that matter. So we help those NPs learn about business so that they can open up their own practices. But they're opening up businesses going to where the patients are, looking at the needs in the communities and addressing those, which I think is a different way to look at healthcare. The other thing is that I put into the chat this NP directory. One of the things that we don't know is where are all these NP practice owners and what types of practices are they providing? There's no way to track that. So our NP directory is hoping to solve that problem by finding out where NP entrepreneurs are and networking them with patients, networking them with each other, and networking them with students so that they can get precepting experiences. But it's going to go, this vision is going beyond that. We're actually going to be looking at communities. And I'll give you an example. In my community, I had a food bank that got a delivery, a semi-tractor trailer truck full of adult diapers. And she gave them to the senior center and to some of the local businesses that she knew of. But the rest of it went to waste. And I said, wouldn't it be great if you could post on this site, any nurse practitioner who thinks that they can utilize these diapers, let us know and we can get them to you. And I'm sure that there had been so many people that would have answered the call and said, yeah, I know patients that need that. So trying to link those community resources to those NPs that are in that community is going to be powerful, I think, to all the discussions that we're having. So we're a movement that's happening. One of the biggest problems that we face is our barriers to practice. We have to abide by certain regulatory requirements that prevent us from providing our care that we can to our top of our education and training. We're making strides. Wisconsin just got full practice authority just the other day. But we need that across the board. We need to be able to mobilize our NPs so that they can feel free to practice to the top of their education and training. So there's a lot to do, but the National Nurse Practitioner Entrepreneur Network is up for the challenge. And I would love to work with any and all of you on this call to help, increase access to care in whatever way we can. Working together, what's the saying? A rising tide raises all boats. And that's what we need to do. So thank you for giving me the chance to speak. I appreciate it.
Thank you, Lynn, and thank you for raising your hand and saying, I want to be a part of this, because that is what I want to do here in a minute. But first, Rachel, I see your hand was up. Rachel Syke, and you're muted at this point. There she is. Still mute. There you go. Oh, can't hear you, but there it comes. We can hear you now.
Okay, can you hear me now?
Yep.
Yes.
Well, I picked up a couple of minutes ago, and I've cycled through several different thoughts since then. So, um, first, I want to work backwards. Lynn, I loved what you were saying. I feel really passionate about working with nurse practitioners. We should definitely connect. But I want to maybe bring up a discussion point about full practice for nurse practitioners. And like I am pro nurse practitioner. I hope that doesn't need to be said, but I think it might need to be. But I wish there were more structural requirements or things that helped me to get supervision as a practicing physician more easily. I think we all need that. And there is something that's kind of nice about, like, because I have to have this, people have to provide it for me, or, you know, like I must seek it. Necessity is the mother of all invention. And if you wanted to weigh in, or anybody else, about sort of the thoughts between tension between the scope of practice and, well, because I think there's a lot of room for improvement in our cultural understanding.
Yeah, it's interesting you bring that up, because I know that there's been some look at primary care physician education and training and reducing the requirements for that in some ways. But again, looking at the nurse practitioner role and not putting barriers to our ability to have full practice. That's one of the things that we're trying to do. Nursing is the only profession that's overseen by another profession, not physical therapists, not pharmacists, no other profession. And so we need to take ownership as nurse practitioners. We need to take ownership of that. You know, our education and training prepares us to do primary care in the majority of situations. And we should be able to collaborate with any healthcare provider to find the best care for patients. That's really what we try to do. And we have a limited scope. There is a line that's drawn that we have to maintain before we, you know, engage in other clinicians to help us out. So, you know, we're not out there practicing in the wild, wild west. We're actually solving healthcare problems. And we just need to be able to have the opportunity to do that without being unencumbered. Just to give you an example, a collaborating physician in some states costs a fortune for an NP to get that. And if you don't have two and you lose your collaborating physician, you are out of regulatory compliance and you must close your doors. So do we want to run the risk of having nurse practitioner-owned practices close their doors for a regulatory reason, not a practice reason, not a patient safety reason? So those are why I think we need to look at, you know, allowing nurse practitioners to practice to our top of our education and training, and, you know, let us do our jobs.
Thank you, Lynn. Thank you, Rachel.
I have a quick follow-up. What do you see the ideal role for nurse practitioners to practice at the top of their education and training? Just like I think there really is one, but I'm just curious about what your thoughts.
We're independent licensed providers right now, so we're able. What we do every day in our jobs is what we're trained to do. You know, there is nothing different. The only thing that is in the way is the regulatory barriers that prevent us from doing some of the things that we can do, like opening up our own practice without being tethered to another provider to do that. You know, and even if, I mean, there's no studies that show that there's any benefit to having a collaborative arrangement or supervision agreement. It doesn't provide any additional safety barriers or any of that. And in COVID, for example, our barriers were all reduced and taken away during COVID. That's 2.5 years of care that NPs were providing. Did you hear a lot of bad things happen? No. So
I'd like, to Paul's comment in the chat, you know, I think that care works better when it's collaborative. And the AIMS model with 22 years of research from the University of Washington has demonstrated that repeatedly. So I think it's the relationship that is critical. And one of the things, I'm listening to all these comments and I'm thinking to myself, you know, what is my wish? My wish is that people would stop saying that the system is broken, because it's not. It is working exactly as it was designed. And it was designed to produce more sick people every year. We've got to get back to the design. We've got to design a system that doesn't just meet medical needs, but all needs. A system that frees the practitioners and healthcare providers to do the right thing. And to give an example of what you were saying, Lynn, in the food bank in Texas, a woman came with a horrible case of shingles that would take a prescription for acyclovir, I think it is. The nurse practitioner could not write that $20 script that she had to send her to the emergency room. So that was an emergency room cost instead of a simple script. There's a time for both, and I think that we know it. But I'm gonna just really say, let's work together. It's gonna take everyone.
So on that note, I would just like to see the hands of people who are interested in being part of this. How many people find this exciting, want to step up? I know that there is room for people on boards of NTH. There's always people looking for communities that might be open to this kind of transformation. I hear hands popping up. This is awesome. Perhaps you know of communities with DPCs already that would be open to this. And I wonder if, who else should be involved in the chat? Who else needs to be involved to break down barriers to make this happen? And then the other question I have for you all is within the framework of our mission, HRC's mission of naming, connecting, supporting, and illuminating the ruckus makers, how can HRC make this happen? Anybody else want to comment? I see lots of hands up. That's awesome. And those of you who are at the forefront of this, make note of that, right? Look at all
I
the
will
hands.
share all of that
Great.
out as well, Dawn.
Excellent. All right. Well, anything in the chat that I need to address before we kind of round things out here? All right. So thanks to our panel guests and to all of you who showed up today. I really appreciate the work that you did to enrich the conversation that we're having around the solutions for health and care. We would like you to keep us posted on the HRC platform so that others who want to be involved can be. The solutions are going to take all of us, right? And as Dr. Pastoor said, nobody's coming to rescue us. It's going to be us that makes this happen. So if you're interested in being involved, like many of you have indicated, we'll put a post up about this on the platform, join the conversation there, and let's see what kind of action happens. Thanks again for joining us today. As healthcare change makers, we aim to understand root causes and find effective leverage points for transformation. Today's discussion demonstrates what can happen when you have passionate people willing to step up. I'm so excited about what's already happening with these three people. So there will be a survey through Zoom when you leave the meeting. Please do fill it out. We really want to hear your input. The link for that Zoom the link for events coming up will be put into the chat. We're about to jump into network conversations where you'll be given an opportunity for one-on-one conversations with someone else on the call. Before we do that, there are a couple of announcements that I want to make sure you hear. So if you'd like to connect with any of our guests or anyone else on the call, reach out on the HRC platform. We encourage you to take advantage of the growing community that we have there. If you appreciate what HRC is doing to bring you together and create events that engage you in this work, we do accept donations on our website. We ask that you give until you feel good about it. And the link to that donation page is also in the chat. Really appreciate you all for coming. Please join the events again. Come back and join us. We really love to hear what you have to say, and do fill out that survey as you leave. But soon we will be going to our network conversations. I'm going to turn that over to Denise.
Thank you, Dawn, and thank you to Sara and Kathleen and Victor for leading this discussion today. I know you only got to tip the iceberg of everything that the work that you're doing and the collaboration that's coming, but I appreciate the share and the openness to engage with others to move this forward. We are going to step into breakout rooms. These are network conversations. This is your opportunity to be able to meet new people or to deepen relationships with those you may already know.